Thank you, everyone. We're returning from our break and we'll reconvene the ACIP meeting. Next, we're moving on to the influenza vaccine session, and we have Dr. Kip Talbot, who will be providing an introduction and overview to today's session.
All right, good morning. My favorite topic is flu. All right, next. Oh, it's noon, sorry. It's been a long day. Okay. So this slide is a list of all of the influenza work group ACIP members, ex officios, and liaison representatives and consultants, and our CDC lead, Lisa Grosskopf. So here's our village. Next slide. So we've been busy this year, but less busy than last year, thankfully. So we have prepared the proposed 2023-24 influenza statement, and we've had an active discussion of the safety of influenza vaccination of persons with egg allergy. And we'll talk about why as we go through the process. But there's been an evidence review, grade, and evidence to recommendation framework, and then development of a proposed recommendation concerning vaccination of persons with a history of severe allergic reaction to egg. Next slide. So today our session is going to include discussion of the influenza vaccination of persons with egg allergy. We'll do the background work group considerations and evidence to recommendation discussion. And then we'll also talk about the proposed recommendations for the 2023-24 influenza season. Next slide. Okay, now I'm done.
Thank you very much, Dr. Talbot. And we'll move on to Dr. Grosskopf to take us through the work group considerations and proposed recommendations for a vote later today.
There we go. Okay, thank you. All right. So as mentioned, we're going to be discussing egg allergy this morning and an ETR and grade for vaccination of persons with egg allergy, particularly those with history of severe allergic reaction to egg. Before starting, I want to thank my colleague in this work, Lene Blanton, and also a number of others, including most particularly Donna Hummel, colleagues in the Immunization Safety Office and Immunization Services Division, as well as our grade consultants, Rebecca Morgan and Doug Campos-Alcalt. So before we get started, a little bit of background first on egg allergy. Egg allergy is a relatively common food allergy affecting approximately 1 to 3% of children by age 3 years. It resolves for many during later childhood and adolescence, and in one study, 68% had developed a tolerance by age 16 years. Reactions range from mild to life-threatening. Diagnosis is generally done by a clear history of immediate allergic reactions to egg or egg-containing foods, as well as skin prick testing or estimation of egg-specific IgE levels. Now, most of the influenza vaccines that are currently available in the U.S., out of the current 7 of them, are produced through the propagation of viruses in embryonated eggs. And so these vaccines can and generally do contain residual amounts of egg proteins, for example, ovalbumin. For 5 of the 7 egg-based vaccines, the egg ovalbumin content is listed in the package insert, and it's generally low, under about 1 microgram. For 2 of those vaccines, egg-based ones, it's not listed. And then we have 2 egg-free vaccines, Flucelvax quadrivalent, which is a cell culture-based inactivated vaccine, as well as Flublok quadrivalent, or a recombinant vaccine. Those 2 vaccines are considered egg-free. However, only 1 of them is approved for children under the age of 18 years, that being the Flucelvax quadrivalent. ACIP currently recommends, and has for a number of years now, that everybody, all persons with egg allergy, should receive influenza vaccine, and it's not necessary to receive an egg-free vaccine. Any influenza vaccine that's otherwise appropriate for the person's age and health status can be used. For those who have a history of severe allergic reaction to egg, and for the purposes of the ACIP guidance, this is defined as having experienced any symptom other than hives, there's a further recommendation that if a vaccine other than CCIIV4 or RRV4, those are the cell culture and the recombinant vaccines, the egg-free ones, is used, it should be administered in an inpatient or outpatient medical setting supervised by a healthcare provider who is able to recognize and manage severe allergic conditions. No specific post-vaccination observation period is recommended. The primary focus of today's discussion concerns the language in the red box and whether to no longer make this additional recommendation for people with severe egg allergy. Some of the reasoning behind this has to do with guidance from other professional organizations. In particular here, the examples are the American Academy of Pediatrics and the Joint Task Force of the American Academy of Asthma, Allergy, and Immunology and American College of Asthma, Allergy, and Immunology. The current recommendations for influenza vaccination for people with egg allergy differ from the ACIP recommendations to the ones of AAP. Since the 2016-17 season, AAP has recommended no additional measures for persons with egg allergy. The AAP 2022-23 Influenza Prevention and Control Guidance states that children with egg allergy can receive any influenza vaccine without any additional precautions beyond those recommended for all vaccines. The technical report that accompanies the recommendations indicates that measures such as the use of specific vaccines, observation periods, limiting vaccination to specific medical settings, and screening for egg allergy are not warranted and constitute a barrier to vaccination. The AAAAI and ACIAI similarly state that no special precautions beyond those recommended for the administration of any vaccine to any patient are necessary for the administration of influenza vaccine to egg allergic individuals. Severe allergic reactions to vaccines overall are uncommon and anaphylaxis is rare, but given their potential seriousness, preparation for such reactions is recommended when administering any vaccine to any recipient. The general best practices guidelines for immunization in the chapter entitled Managing Adverse Reactions notes that allergic reactions are uncommon and anaphylaxis following vaccines is rare, but it also notes that vaccination settings should be prepared for potential serious reactions, noting that epinephrine and equipment for managing an airway should be available for immediate use. As a last piece of background, some information on previous approaches to influenza vaccination of egg allergic individuals. I should be very clear that none of these is currently recommended and they have not been recommended for some years, but we raise them because they're relevant to the literature review we'll be summarizing later. In one previous approach, skin prick testing with egg protease and or intradermal testing with dilutions of vaccine were done. If positive, vaccination might be deferred or an alternative administration dosing protocol might be selected. Two of the main types of alternative protocols for administering vaccines, particularly the intramuscular vaccines, include graded administration of vaccine and split dosing of vaccine. For graded administration, this involves incrementally increasing volumes, more than 3 steps, generally often in 5 to 6 steps, sometimes with dilutions of vaccine in the very early steps, and observation periods after each installment is given. These are referred also in the literature as desensitization protocols. A later approach was split dosing of vaccine, generally with the vaccine, the total dose volume that was needed being administered in 2 steps, most commonly 10% of the dose volume followed by an observation period, then 90% of the dose volume, often with an additional observation period after the final dose. Again, neither of these are currently recommended. However, they are a part of the past literature that we'll be discussing. With that background, the policy question here is whether to no longer recommend additional safety measures for people with egg allergy of any severity beyond what is recommended for any other recipient of any vaccine. In the discussion that follows, the proposed intervention is to no longer make the recommendation regarding vaccination setting for those with a history of severe allergic reaction to egg. So with that background, we'll summarize the workgroup discussion of the evidence to recommendations framework, starting with the first domain, public health importance. So is vaccination of egg allergic persons an issue of public health importance, or framed slightly differently, how important is vaccination for this population? While influenza vaccination is important and recommended for all persons 6 months and older, there are some that are increased risks of severe illness due to influenza, and some egg allergic individuals might fall into this category. For example, egg allergy is more common in younger age groups. As we saw at the beginning of the presentation, egg allergy is sometimes something which resolves as children get older. Also, egg allergy frequently coexists with asthma. In one series, asthma prevalence was higher among children with egg allergy than with the other 8 most common food allergies. Younger children and people with asthma are groups that are recognized as being at increased risk for severe influenza illness and are populations for which barriers to vaccination might be more consequential. In the work group discussion, a number of points were raised related primarily to potential increased risk for some people with egg allergy and also how consequential are potential barriers or do they even exist. On the one hand, current recommendations might be a real or perceived barrier to vaccination, for example, by promoting hesitancy based on safety concerns or providing a reason to decline vaccination. This could be detrimental to egg allergic persons who are at increased risk of severe influenza. No data specifically examining or confirming that the current recommendations as they stand are an actual barrier, but the existence of a real or perceived barrier from the current language is plausible. On the other hand, some work group members raised the point that current recommendations might be less of a barrier now than they were previously, since the cell culture-based vaccine, Flucelvax quadrivalent, is currently approved for ages greater than or equal to 6 months. Up until relatively recently, it was only for 4 years and older. So now it goes to the youngest age group that probably have the highest prevalence of egg allergy. However, it's important to consider also that there is only one vaccine that's egg-free that's licensed for children under 18 years compared with 4 other vaccines that are egg-based. In polling on this question, 95% of the work group responded either yes or probably yes to the question of whether vaccination of egg allergic individuals is an issue of public health importance, with only 6% of the total responding probably no. Next, the second domain, benefits and harms. This will probably be the longest part of the presentation. To address this domain, systematic literature review and grade were done. As mentioned earlier, the policy question and the proposed intervention are whether to no longer make the recommendation regarding vaccination setting for those with a history of severe allergic reaction to egg. Now, there's a bit of a disconnect here because it seemed very unlikely that we would find data directly addressing the question of whether having that additional recommendation is consequential or not, specifically the recommendation with regard to setting. Therefore, the review focuses on the safety of influenza vaccine in this population, addressing the question, does the available evidence concerning the safety of influenza vaccine in persons with a history of egg allergy favor routine vaccination without additional safety measures, regardless of severity of previous allergic reaction to egg? Now, because all egg allergic individuals are currently recommended to get flu vaccine, and we are not looking at the question of whether or not to vaccinate or whether to choose specific vaccines, this review focused solely on harms and did not include review of efficacy or effectiveness data. The PICO was as described here. Population was persons of any age with a history of allergy to eggs or who have had an allergic reaction to influenza vaccine believed to be secondary to egg allergy. Interventions included any influenza vaccine. We did include actually non-egg-based vaccines in this, and we'll talk a little bit more about one of these later. Comparators of interest included placebo, non-egg-based influenza vaccine, non-influenza control vaccines, no vaccine, or no comparator. We had a total in the final run-through of this 6 outcomes. These were to have occurred ideally within 4 hours of vaccination. Critical outcomes were death, anaphylaxis meeting Brighton criteria levels 1 through 3, anaphylaxis otherwise classified, and allergic symptoms requiring hospitalization. You'll see in the tables that follow that the 2 anaphylaxis outcomes have been combined. Important outcomes included allergic reaction symptoms requiring outpatient or emergency department medical attention, and for this category, we did include instances that were described as being treated with medications, for example, symptomatic medications, even if it was not explicitly stated that transfer to another level of care or an emergency department was done. The last important outcome was allergic reaction, including cardiovascular symptoms, respiratory symptoms, angioedema, or generalized urticaria. The basis for inclusion of this set of reactions was these are the things that fall short of anaphylaxis but might nonetheless be considered worrisome. The systematic review yielded a total of 47 reports, which we included, describing 52 studies. There was only one randomized study, and this was a comparison of full dose with 10%, 90% split dosing of vaccine. There was one VAERS report summary, and the remainder were retrospective and prospective cohort studies in case series. 2 involved only recombinant vaccine, which is egg-free, but we'll get to those a little later. Of interest, none of the studies included a relevant comparison group. For example, an alternative intervention such as no intervention or a different vaccine, an egg-free vaccine. In general, these studies took a population of individuals with egg allergy, administered vaccine, and then followed them for reactions. 14 of the reports were abstracts only with no related paper found, so they had relatively limited information. All of these papers and reports and studies were reviewed descriptively. However, 28 reports encompassing 31 studies were included in grade. The studies included in grade were of egg-based vaccines only, both seasonal and monovalent pandemic vaccine. They included either full or split dose administration. And those 2 administration methods were combined in the data. And this was because after consultation with an allergist, it was determined that these 2 administration routes were similar from the point of view of risk of an adverse reaction. For the randomized study, which compared full versus split dose, those 2 experimental groups were combined, and this study was treated as a cohort study. Data with unknown or unclear vaccine type, unspecified administration protocol, studies which used a graded protocol of 3 or more steps to administer vaccine, or which had an unknown or unclear denominator were excluded. Since there are no comparison groups for the work which we're summarizing, the data are summarized as frequencies, and this is the first time I've done grade without forest plots. So you're going to look at, I'm sorry there are no pretty pictures, but I love a good forest plot. But the detailed grade tables are in the back of the presentation as extra slides, and in the interest of time, we're not going to go through those chapter and verse. What you're going to see on the next 2 slides is a summary, basically, of the frequency of the events that occurred by vaccine type. You can see we stratified in the columns, we stratified these results by vaccine type, seasonal IIVs, monovalent IIVs, and LAIV. All of the LAIV work was with seasonal vaccine. The seasonal IIV group includes 1 virosomal vaccine. That's a vaccine not available here. It was a study from Europe. We did assess grade and evidence certainty for every vaccine and outcome separately. However, the results were all the same, so in certainty, you're going to see only 1 column just for space considerations. Certainty levels, just to quell any suspense, were very low across the board, and we'll explain why. So with regard to the event frequencies, the included papers reported no occurrences of the 3 critical outcomes, death, anaphylaxis, or hospitalization across vaccine type. For reactions requiring outpatient or emergency department attention, frequencies were 0.2% for seasonal IIV, 1.5% for monovalent IIV, and 0 for LAIV. I should note here, as we talk about that particular category, I mentioned that we included instances that involved treatment with symptomatic medications. That, in fact, was the majority of these. There were only 2 that referred explicitly to transfer to an emergency department. For reactions including cardiovascular symptoms, respiratory symptoms, angioedema, or generalized urticaria, frequencies were 0.3% for seasonal IIV, 0.6% for monovalent IIV, and 0.8% for LAIV. Again, certainty across the board was very low. For these studies, generally, they were all observational studies, so they started with a certainty of low. Downgrading even for 1 category for 1 characteristic is going to bring you to very low. This work as a overall was downgraded mainly for methodological quality and for imprecision. This particular slide, these data, because they reflected data for people with egg allergy of all severities and not just those who had a history of anaphylaxis to egg, was also downgraded for indirectness. So next we have a similar slide, but this time we're talking about the subset of individuals in these studies that could be found that were reported to have a history of anaphylaxis to egg. Since the policy question really focuses on people that have a history of severe egg allergy, this group is important to us and we were hoping to find as much as possible, so we stratified these data out where we could. Overall, the numbers are lower, as you can see. Some studies did not include people with severe egg allergy, or they did not mention whether or not they did, or they didn't say what the numbers of those people in the study were, or most commonly, if they included people with a history of anaphylaxis to egg, they didn't report the findings specifically for that subgroup. They might have reported reactions, but then did not go on to say whether they occurred or how many of them occurred in people with anaphylaxis to egg. So as you can see, overall, our numbers are lower. There were no events for any of the outcomes interest for any vaccine type in this subset. This is likely, at least in part, due to small sample size. Certainty for these outcomes was rated as very low for each vaccine type as well, with downgrading primarily for methodological quality and imprecision. So this slide summarizes the evidence for our outcomes of interest. Again, we did do this separately for each vaccine type, but it was very low for all three vaccine types, so we've consolidated this into one table. For our three critical outcomes, as well as our two important outcomes, overall certainty in the evidence, very low. Now, I'd mentioned that studies without denominator data were not included in grade, as well as those for which the vaccine was unclear, but there's one particular report that bears noting in this discussion. This was one report of Brighton level 1 anaphylaxis that occurred in a person with possible egg allergy within 30 minutes of receiving monovalent vaccine. It was reported in a paper summarizing VAERS reports of adverse events to monovalent pandemic vaccine during the 2009-10 season. The information presented on this case in this paper is very limited, and it is actually unclear from the way it's described whether the recipient was documented to be egg allergic. It's referred to as a case of possible egg allergy. The reactions not included in the counts in the grade evidence profiles, again, because we don't have a defined denominator, this being VAERS data. The paper does state that approximately 127 million doses of influenza vaccine were distributed that season. However, we don't know the number of doses that were actually administered. 3 other reactions among egg allergic persons were reported in this paper, which included 2 described as respiratory hypersensitivity and 1 a sensation of throat closure. I did mention we would talk about a couple of papers related to egg-free vaccine. These discuss reactions following recombinant influenza vaccine, and they are from Wu et al., 2015 and 2017. And these are summaries of VAERS reports following administration of recombinant flu vaccine. They include reports of serious allergic reactions following RIV, some of which occurred among persons with egg allergy. RIV is egg, gelatin, antibiotic, and preservative-free. Now, because we are dealing with an egg-free vaccine, these reactions can't really be assumed to be a manifestation of egg allergy. However, this literature brings up a couple of points that are probably important. One that the authors note is that the occurrence of such reactions might reflect an underlying predisposition to atopy among egg allergic individuals. Also, it highlights the importance about thinking about the unpredictability of severe allergic reactions and the importance of being prepared in all vaccination settings for all recipients and with all vaccines. So there are a number of limitations to this review and the literature retrieved, and these things were discussed within the work group. Again, we have observational data with no comparator groups meeting criteria. So not only is it observational, but most of our cohort studies are essentially case series because there's no comparator group. One thing I should mention that I didn't earlier is that there were a small handful, about 4 studies that included a comparator group of non-egg allergic people, but that wasn't the kind of comparator group that was going to give us the information we really needed. Some of the data are available only from abstracts, which of course have relatively limited detail compared with the paper. Many of the, particularly of the older papers, employed skin testing with egg proteins and/or vaccine prior to deciding to vaccinate or deciding how to vaccinate, for example, full versus split dose. So it's possible that there could have been some kind of a selection bias caused by that procedure. There is considerable variability in the level of detail in which outcomes are described. I mean, particularly in abstracts, descriptions are sort of scant, but even among papers, there's variability in the level of detail. It is probably reasonable to assume that serious reactions such as death or anaphylaxis are more likely to be reported than less serious ones. But even among less serious ones, there was some variability. Most studies did have a follow-up period for delayed reactions to be reported by parents or caregivers, perhaps 24 to 72 hours after discharge from the vaccination setting. But it's easy to see how some of these reactions might not be described as well, and instances of outpatient care or hospitalizations might be missed. Another thing is that observation time post-vaccination varied, and it was often not reported for the delayed reactions. We had hoped to capture as acute reactions, we were being pretty conservative, those that occurred under 4 hours after vaccination. However, pretty much across the board, observation times ranged between 30 minutes and 2 hours. And even among those authors that reported delayed vaccinations, they often did not report the elapsed time post-vaccination, which made the data difficult to use. Ovalbumin content was not reported or unknown in most instances. Some authors did report it, relying on either the package insert. Some even actually had vaccine assayed themselves. In most instances were noted it was under 1 micrograms per dose. In some cases, substantially less. In particular, one of the monovalent vaccines used in some of the studies, Aripanrix, had an unusually low ovalbumin content, as did the virusomal vaccine, which was in one of the studies. It's really difficult to know how this compares with current vaccines, since the current vaccines in the package insert that do cite this information express it as an upper limit, and there's a number of papers previously that show that the quantity of ovalbumin can vary from lot to lot. Finally, and this is maybe the most important one, data specifically for people with anaphylaxis to egg were very limited. Not all studies specified they included them, some didn't include them, and where they included them, they didn't always report data specifically for that population. As a last piece of information here, we're fortunate that our colleagues in ISO did a brief review of VAERS reports for egg allergy and anaphylaxis for the 2017-2022 period. We're really grateful to Pedro Moro and colleagues for putting this together. In their review of VAERS reports, there were a total of 178 anaphylaxis reports after IIVs and activated vaccines, 18 of which were reported to have an egg allergy. Clinical review of these reports revealed 7 of anaphylaxis and egg allergy, all of which occurred in the 17-18 season, 4 among children, 3 among adults. There were 4 Brighton level 1, 1 Brighton level 3, and 2 did not meet Brighton. Influenza vaccines associated included Fluarix quad in 2 instances, Fluzone quadrivalent in 2 instances, Fluvirin trivalent in 1 instance, Flucelvax quadrivalent, the cell culture-based vaccine in 1 instance, and Flublock quadrivalent in 1 instance. Difficult to assess whether the reaction was due to egg protein in these instances due to limited laboratory data. So with regard to the question of benefits and harms, because this review focused solely on safety literature, only one of the benefits and harms questions was addressed. For the question of how substantial are the undesirable anticipated effects, 83% of respondents selected either small at 44% or minimal at 39%. 6% one vote was for moderate, and 11% selected varies. Next, moving on to values. So with regard to the first values question, does the target population feel that the desirable effects are large relative to the undesirable effects? No direct evidence to support any conclusions here was found. It was raised that a change in the recommendations might be reassuring to some who have wanted to be vaccinated but were hesitant or perceived it to be unsafe. It was also raised that it might be a source of concern for some people, with one workgroup member expressing that the change might be viewed unfavorably if it is perceived as a trade-off between safety versus increasing coverage and reducing missed opportunities to vaccinate. For this question, there really wasn't a majority opinion for any single answer, but half of respondents responded don't know, probably reflecting lack of information to inform this particular question. And you can see that there was considerable dispersion among the other options, although none selected no. Regarding whether there is important uncertainty about or variability in how much people value the main outcomes, no direct evidence to support conclusions here was found. Presumably, greater value might be attached to the more serious outcomes, such as death, anaphylaxis, and hospitalization, which were the critical outcomes. But again, we found no data to support anything here. For this values question, there was a more clear majority response than the previous one, with 67% indicating that they felt that there was probably not important uncertainty or variability in how people value the main outcomes. However, 28% selected that there is probably important uncertainty or variability. So moving on to the next domain, acceptability. So with regard to acceptability, no direct evidence from stakeholders found. However, there is some information which speaks to indirectly to the possibility of acceptability. Some information speaking for acceptability includes the fact that several U.S. professional societies already recommend that no special measures, screening, observation periods, selection of specific vaccines, specific vaccination settings are needed for those with egg allergy. A potential factor against acceptability is that as of 2022-23, package inserts for egg-based vaccines continue to carry a contraindication for severe hypersensitivity reactions to any vaccine components, which for egg includes egg-based vaccines. And this is something that could cause confusion among both providers and consumers. However, this is a contraindication that's been in place for quite some time, and ACIP has also previously recommended for some number of seasons now flu vaccination with any appropriate vaccine, including egg-based vaccines, for people with egg allergy, regardless of severity to reaction to egg. So there's probably not a priori reason to assume that a change in recommendations would substantially affect acceptability. In further discussion with the work group, considerations regarding acceptability included the idea that alignment of recommendations among public health organizations and professional societies facilitates consistent messaging to providers and patients. However, some expressed the concern that some settings might not be prepared to manage severe reactions, even though the guidelines state that preparation should be in place. And also further, that acceptability could be severely negatively impacted if anaphylaxis occurs in a setting unprepared to manage it, in particular if there's a bad outcome. This same work group member raised the importance of stressing that every setting must be prepared to manage anaphylaxis or should not be administering any vaccine to any recipient. Finally, there's concern for potential liability issues. With regard to whether a change in recommendations would be acceptable, 44% of 18 respondents indicated yes, while 56% indicated probably yes, with no responses in the negative. Next, resource use. Following consultation with our center health economist, no economic analysis was conducted for this review. Reasons include that the target population is small, and also that there's lack of data for some factors which would be important in constructing the needed assumptions for an economic model. For example, we don't have a reliable estimate on the proportion of those with egg allergy who have had severe reactions to egg. Proportions of individuals with egg allergy by age, particularly as you get into older age groups, is less certain. And importantly, there's little information on the proportions of persons with egg allergy who are receiving egg-based versus egg-free vaccines. Finally, the primary emphasis of this review was on safety rather than cost. So again, while the intervention discussed here is not really one that has to do with the vaccines per se, we're not discussing whether to recommend some vaccines over others. The point was raised that a change in recommendations with regard to setting could lead to influenza vaccination of egg allergic persons being achieved in a more widespread manner in more settings, and that could in turn lead to a change in the balance of use of egg-free versus egg-based vaccines in this population. So with that in mind, we did examine cost data. Average wholesale cost data are not available, but we're able to get some information from CMS payment allowances and also from the VFC price list. So here we have data that's from the CMS reimbursement rates for 22-23 and the VFC cost list for 23-24. Overall, CMS payment allowances and VFC costs are higher for the egg-free vaccines that are approved for children. You can see them here rounded to the nearest dollar. In particular, for both the multi-dose and the preservative-free single-dose formulations of Flucelvax quadrivalent, the egg-free cell culture-based vaccine, these costs are about $9 to $11 higher than the average corresponding presentation for the egg-based inactivated vaccines. Workgroup considerations around the issue of resource use included that removing existing restrictions could possibly result in a more efficient allocation of resources if the data suggest no or minimal increase in adverse events. On the other hand, a change in recommendations and lower cost of egg-based vaccines might lead to their increased use, which might be associated with increased costs if there is increase in reactions that require medical attention. With regard to whether the intervention is a reasonable and efficient allocation of resources, of 17 respondents, we excluded one here who chose 2 options, probably yes and yes. Of the 17 remaining, 76% responded yes and 24% probably yes. So we're going to move on now to equity. We were not able to find any direct evidence that would affect conclusions in this particular population of egg allergic individuals. However, some indirect evidence concerning risk of some populations to severe influenza illness, as well as prevalence of egg allergy, are raised here as potential indirect lines of evidence. For example, some racial and ethnic groups are at increased risk of severe influenza illness, highlighting the importance of flu vaccination. One paper recently reported that influenza-associated hospitalization and ICU admission rates were higher among Black, Hispanic, and American Indian, Alaska Native children under 4 years of age compared with white children. Additionally, some studies indicate that some groups are more likely to have food allergies. For example, Black children were disproportionately represented among children with egg allergy in one series. If current recommendations are in fact a real or perceived barrier to vaccination, the intervention could potentially improve equity with regard to risk of severe influenza illness in this population. Issues related to trust in the healthcare system were brought up by a couple of workgroup members, and these are things that would speak towards the negative. It's a little complicated to express. Again, we're not talking about recommending egg-based versus non-egg-based vaccines, but this point sort of brings together the issues of cost, equity, and trust. The proposed recommendation focuses on language related to vaccination setting, and egg allergic people are currently recommended to receive any vaccine that's otherwise appropriate, even if it's egg-based. However, again, a change in recommendations might mean that vaccination occurs more widely in more settings than previously, perhaps with increased use of egg-based influenza vaccines rather than egg-free vaccines in some settings, which could be influenced by their relative cost. The fact that egg-based vaccines are less expensive might reinforce the belief that vaccination providers do not care to use the necessary resources to provide a potentially safer vaccine. With regard to impact on health equity, the workgroup responses were somewhat more dispersed than for many other domains, possibly reflecting uncertainty given the lack of specific data. However, half of 18 respondents expressed that equity would probably be increased. So our last domain is feasibility. There were a number of considerations brought up concerning feasibility, which are summarized here on either side of the slide. So considerations favoring feasibility are that the proposed change is a simplification of the previous recommendation. It involves removal of an extra recommendation for one subgroup, and it makes the recommendations for vaccination of egg allergic persons uniform regardless of severity, and in fact, similar to basically the recommendations for vaccination of any person against influenza. It also does not specify particular vaccines, and it also does not change recommendations for emergency equipment and resources in vaccination settings. As noted, the general best practices already indicate that equipment and medicines to manage an airway and to manage a potential severe allergic reaction should be available in all vaccination settings. A consideration against feasibility is that there might be some vaccination settings not already prepared to manage severe allergic reactions, and such settings would need to address these needs. However, again, all settings are already recommended to be prepared for severe allergic reactions when administering any vaccine to any recipient. With regard to whether the intervention is feasible, of 18 respondents, 89% responded yes and 11% probably yes. So our last two bits of information are balance of consequences and sufficiency of information. For balance of consequences, of 18 respondents, 61% indicated that desirable consequences clearly outweigh undesirable consequences in most settings. 39% responded that desirable consequences probably outweigh undesirable consequences in most settings. And with regard to whether there's sufficient information to move forward with the vaccination, of 18 respondents, 18 responded yes and 0 responded no. So with this, draft language for a proposed change in the recommendations was made, which is shown in the next presentation, but I would be happy to take any questions. Thank you very much for your attention.
Yeah. Thank you, Dr. Groskopf. This presentation is now open for questions. Dr. Daly.
Thanks so much for this. I have a question, and it might be best directed for Dr. Shimabukuro and then also perhaps for our representative from the Pharmacists Association. But realizing we're talking about influenza vaccine here and not COVID vaccination, is there any evidence that the COVID vaccination program led to more people being vaccinated in settings without the proper equipment and training to address anaphylaxis in the moment? Thank you.
This is Dr. Shimabukuro. I don't know the answer to that. I may not be the best person to address that issue about vaccination in those settings.
Okay, so Tom, it sounds like not specific VAERS reports, that sort of highlighted that issue.
Well, I mean, if we wanted to get at that through VAERS, I think we'd have to conduct an analysis. But since VAERS is passive, I'm not sure if the VAERS data would be the best to address that specific question.
Dr. Paley.
I want to say thank you to Dr. Groskopf for you and your team for investigating an important topic with information that is not easy to find. And you have done a very nice job of presenting it. And what I am taking away from this, I want to just make sure I'm summarizing it correctly, is if we look at people who have a known anaphylactic reaction to eggs prior, we had no of the severe events. And when we look at the data for vaccines administered in the United States, the monovalent IIV being not the pandemic version, but it's another country's version. Is that correct?
Monovalent IIV here basically refers to the pandemic influenza vaccine that was used during the 9-10 season. And some of those studies were US, some were Canada. So they weren't all US studies. I believe there was even one from Europe. Interestingly, there were quite a few studies from that season. What appeared to have happened was just divining this from the context of the background information about why people did the studies. When the pandemic arrived, there was concern about being able to vaccinate people with asthma. And so some of the studies from this period actually were focused on individuals with asthma, but had some people with egg allergy. But also because asthma, atopy, egg allergy sort of coexist, that led to this sort of cluster of egg allergy studies that were published between about 2010, 2011, 12. And interestingly, if you look at the dates of the publication of the literature we netted, there's this peak around 11, 12, and then things really quiet down. There's another peak in 2015 where the 3 LAIV studies were performed, and since then there's very, very little. And I've been told anecdotally this is because in the allergy community they don't consider this a further issue. So it's always difficult to say for sure we will not see more on this question, but the allergists seem to be saying we will not be seeing very much more on this question if we look at sort of the publication paper, dates of publication that we have. I'm sorry, that was a bit beyond what you asked, but reminded me of an important point.
So thank you, because it also, when you have a severe allergy, typically an allergy immunologist is consulted. And so that is also reassuring that this is a very safe way to go. And I appreciate it. Thank you.
Thank you. Dr. Brooks?
Yes, excellent presentation. Can you go to slide 20 or 21? It really doesn't matter. Either slide 20 or slide 21. Okay. And, okay, one by one, it's all good. Get a review.
Was it that one?
Either one, yeah. So the only I'm asking, the certainty was very low, only because there was no comparator?
Well, we were starting from a baseline of low because we had observational studies, and in addition to that, we had observational studies with no comparator groups. We didn't just carte blanche say just because there are no comparator groups, we're downgrading everything one level further, but we used a tool for the assessment of case series and case reports, which is not one we've used previously by Murad et al., which has a series of questions to ask about studies that don't have comparator groups. So we did actually rate on the, not on the outcome level, but on the paper level, each paper. And so the overall assessment for each vaccine and outcome combination reflects the assessment of all 4 domains, including methodological quality for which we use that tool. So it wasn't that we just decided everything is very low because they're observational and they have no comparator groups.
Okay, because obviously this is very reassuring, but I can only take it with, I won't say grain of salt, but I can't really feel strongly about it, though. Still looks really good. You got almost 1,000 as an N, if you add them all up. Thank you.
Thanks. I think this is one of the issues we struggle with grade for safety data because often for the serious events, the data does come from observational studies because if something is very rare, you might not have power to pick it up in an RCT. So it does feel sometimes as though we're always struggling with our safety data starting at a slightly lower level.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the In response to the question about safety in vaccine clinics, a lot of the mass vaccine clinics, and we were on everything and related to adverse events, and so they were prepared with EpiPens and they had everything. I see that Dr. Good has raised her hand. I'll let her answer for the pharmacist.
Please go ahead, Dr. Good.
Yes, thank you. So pharmacists do receive training in managing anaphylaxis and would also have epinephrine available and be able to follow the best practices for managing allergic reactions in the pharmacy setting.
Are there any additional questions about that presentation? Dr. Daly.
So I'm going to sound like a Boy Scout here, but so then the motto is be prepared. Is that right? So no. So I mean, I think it just highlights just continued education, which I think if anything, the COVID vaccination program probably reinforced, but I just think we want to continue to highlight that in all of our messages to any immunization setting. So yeah, thanks.
Thank you. I don't see any additional hands raised. So Dr. Groskopf, do you have one more presentation you'd like to give?
Yes, please. Okay, got it. Okay, let's see if I can get the slides to advance this time. So thanks very much for your attention on that last one. This one will be shorter. In this presentation, we're going to go over a brief influenza vaccine safety update and also the proposed recommendations for next season. Yes, it works. Okay. Before starting, I want to thank a number of people, including the CDC attendees on our work group calls, who I can always rely on to help me when I need more information about things I don't know anything about. Immunization Safety Office colleagues, Immunization Services Division colleagues, our CDC librarian, who is amazing for our systematic reviews, and also Donna Hummel, an allergist at Vanderbilt, who works with the ACIP project, who has been incredibly helpful with our allergy discussions. So first, we're going to have a very short one-slide influenza vaccine safety update. This is something that we try to do every June, even if there's not much to talk about. We do it at the end of every season. This is a slide that, once again, grateful to our ISO colleagues for putting this data together. The summary is that approximately 173 million doses of influenza vaccine were distributed in the United States for the 2022-23 season. In the Vaccine Adverse Event Reporting System, or VAERS, which is co-managed by CDC and FDA, no new safety concerns were identified for influenza vaccines. In the Vaccine Safety Data Link, or VSD, which is a collaboration between CDC and 9 integrated healthcare organizations, within the VSD, there were approximately 5.5 million doses of flu vaccine distributed for the season. No new safety concerns were identified in influenza vaccine safety monitoring. However, as you're aware, there was a statistical signal for ischemic stroke after Pfizer-BioNTech bivalent mRNA COVID-19 vaccine in persons aged 65 years and older that was detected in VSD analysis for COVID-19 vaccine safety monitoring, as previously presented to ACIP. As you are aware, post-signal analysis in VSD found an elevated rate ratio for ischemic stroke after simultaneous vaccination with Pfizer-BioNTech bivalent mRNA COVID-19 vaccine and high-dose or adjuvanted influenza vaccine, which is attenuated over time. Separate analyses did not detect elevated rate ratios for ischemic stroke after influenza vaccine administered without bivalent mRNA COVID-19 vaccine. So next, an overview of the proposed recommendations for 23-24. We're going to just discuss a few aspects of this. The first point to bring up is that vaccination of all persons aged greater than or equal to 6 months who do not have contraindications continues to be recommended. No change there. Additionally, there are no changes proposed for the recommendations regarding timing of vaccination as compared with this past season. We are going to summarize the timing of vaccination language for programmatic reasons in just a minute. Changes include, or proposed changes include, the updated U.S. influenza vaccine composition for 23-24 and proposed changes to the recommendations for vaccination of persons with egg allergy. So first, a little bit on timing of vaccination. The timing of vaccination recommendations that are proposed are unchanged from last season, but because this information is important for programs in terms of planning their flu vaccine campaigns for the upcoming season, we're just going to go over them today briefly. The core recommendations are here, sort of the overarching ones, is that for most persons who need only 1 dose of flu vaccine for the seasons, that is all adults and many children that are included in that group, vaccination should ideally be offered during September or October. And the reason that that is the case and not earlier is because of concerns for waning of immunity during the season. However, vaccination of unvaccinated persons should continue after October and throughout the season, as long as influenza viruses are circulating and an unexpired vaccine is available. Vaccination during July and August are not recommended for most groups, as noted above, due to concerns for waning immunity. Considerations for July and August vaccination are noted for adults, children, and pregnant persons. We're going to go over each of those groups briefly. For most adults, particularly adults age 65 and older, and for pregnant persons in the first or second trimester, vaccination during July and August should be avoided unless, and there is an unless here, there's concern that vaccination later in the season might not be possible, i.e. you're concerned that you're going to miss an opportunity to vaccinate at all. And this is because, particularly for adults 65 and older, we are concerned about waning immunity over the course of the season, which appears to be, has been documented in all age groups, but appears to be the most pronounced among older adults. For children, there are 2 recommendations. Those who require 2 doses, these are children who are aged 6 months through 8 years who have either an unclear, unknown influenza vaccination history or who have not received a lifetime total of 2 doses. Those children should receive their first dose as soon as possible, including during July and August if vaccine is available, to allow the second dose, which has to wait for 4 weeks before it can be given, to be received ideally by the end of October. Children who require 1 dose, for these children, vaccination during July and August can be considered, and this is because while we're not completely unconcerned about waning among children, waning has been documented in all age groups. There are less data currently for children. Moreover, school-age children commonly present to healthcare providers in the late summer months for preschool physicals, so this presents a vaccination opportunity, which is particularly something to be considered if you think that you might not see that child again. Next, pregnant people in the 3rd trimester. For this group, vaccination during July and August can be considered because vaccination might reduce risk for influenza illness in their infants during the first months after birth when they are too young to receive influenza vaccine. This has been documented in a number of studies. So now to our proposed changes. One is really not our proposed change. It comes from FDA, and even if we voted on it, I don't think we have a choice. But this has to do with the influenza vaccine composition for 23-24. We note this in the statement every year. FDA's RPAC met in early March, as usual, to select the recommended composition for the next season. All vaccines available in the U.S. next season or expected to be available will be quadrivalent. The 2023-24 composition includes updated influenza A, H1N1, PDM09 components for both egg-based and non-egg-based vaccines. You can see those here. Interestingly, this has caused a little bit of confusion in some questions because the H1N1 PDM09 components last year were also in A Victoria and in A Wisconsin, but they were actually a different A Victoria and an A Wisconsin with slightly different numbers in their taxonomy. The components for the H3N2 and for both B viruses are the same as last season. And lastly, proposed recommendations for vaccination of persons with egg allergy. So as mentioned at the end of the summary of the review, proposed language was drafted for consideration and editing as appropriate. The egg allergy, the meat of the recommendations is basically 3 bullets, which are presented here. The first, all persons aged greater than or equal to 6 months with egg allergy should receive influenza vaccine unless a contraindication exists. Any influenza vaccine that is otherwise appropriate for the recipient's age and health status can be used, egg-based or non-egg-based. Second, egg allergy in and of itself necessitates no additional safety measures for influenza vaccination beyond those recommended for any recipient of any vaccine, regardless of severity or previous reaction to egg. Finally, severe and life-threatening reactions to vaccines can rarely occur with any vaccine and in any vaccine recipient, regardless of allergy history. Providers are reminded that all vaccines should be administered in settings in which personnel and equipment needed for rapid recognition and treatment of acute hypersensitivity reactions is available. All vaccination providers should be familiar with their office emergency plan and be certified in cardiopulmonary resuscitation. I believe that is my last slide. Yes. Thank you very much.
Thank you. This presentation is now open for discussion. Dr. Long.
Dr. Grosskopf, could you go back to slide number 4, please?
I should have numbered these.
Oh, maybe it's a different number.
Can you remind me, Dr. Long, of the title of number 4?
Vaccine Safety Update 2022-23.
Thank you very much.
It's the one that has the footnotes.
Oh, thank you. Yes.
It is in regards to the footnotes
There
that
we
I
go.
have a question. Okay. So I'm thinking about asterisk 2 asterisks. No new safety concerns were identified in influenza vaccine monitoring. And then below it says, that includes acute disseminated encephalomyelitis. So my question is, because this has come up in our RSV work groups, we said, and we, in that group, that there were no non-live vaccines that there had been a concern for ADEM. So the question is, why was VSD looking for ADEM? Just as Veronica asked, why was somebody looking for atrial fib? Had there been a signal of ADEM associated with influenza vaccine?
If Dr. Shimabukuro is still on the line, I'd welcome his input on this question.
Sure. I think the question was about safety outcomes being monitored in VSD and any new signals or the rationale for monitoring those. So the double asterisk footnote are the pre-specified VSD rapid cycle analysis outcomes that we're monitoring. And as far as acute disseminated encephalomyelitis, there hasn't previously been a statistical signal for that outcome, but it is one of the outcomes that we have traditionally monitored. There have in some previous years been statistical signals for Bell's palsy and Guillain-Barré and febrile seizure, but those are outcomes that we have monitored for the past several flu seasons. We monitor all outcomes in VSD because it's passive. So whatever is sent to us, we monitor, but we did not see any signals for ADEM or GBS or Bell's palsy or encephalitis or seizures or transverse myelitis during this flu season.
Since you're the font of all knowledge of safety, do you know of any association or signal to be investigated for ADEM with any non-live vaccine? We know about MMR and the rare association, but do you know about ADEM in any non-live vaccine?
So there is a for yellow fever vaccine, there is a syndrome called yellow fever vaccine associated neurologic disease, which is pretty well known and well characterized. And that includes conditions like ADEM and GBS and meningoencephalitis. For an older type of rabies vaccine, there was evidence of an association with ADEM and the older rabies vaccine. I mean, as far as MMR, I'm not aware of any association between MMR and ADEM. And in fact, this is an outcome, vaccine adverse event pairing that the Institute of Medicine looked at back in its 2012 report, where they look at both epidemiologic evidence and mechanistic evidence. And for the epidemiologic evidence for MMR vaccine and ADEM, they concluded the evidence was insufficient or absent. And then for the mechanistic evidence, they concluded that it was weak based on knowledge of natural infection. So their overall conclusion was the evidence was inadequate to accept or reject a causal relationship between MMR vaccine and ADEM. So besides the yellow fever vaccine and the older rabies vaccine, I'm not aware of any vaccines with an association, an established association with ADEM, and certainly not for any routinely recommended vaccines.
This is Jim Save, our CDC. It should also be noted that for the yellow fever and the rabies vaccines that were in question with ADEM, those were the neural tissue derived vaccines. So were of inherent greater risk.
Thank you for this very thorough responses. Are there any additional questions? Okay, Dr. Paling and then Dr. Cotton.
I have a comment and then I was going to make a motion. Is it correct that we need a motion? Okay, fantastic. So I have a comment. First of all, I wanted to thank you for the conversation on the timing of influenza vaccine, and I do hope some of the distributors are on the call. The perception, at least in our region of the country, is that the large pharmacies tend to get the vaccine first. And as we've talked about, we said that the group that can get the vaccine early, though not necessarily recommended to be starting in July, would be your children, which means your VFC and your pediatric practices. And sometimes that is the only time we will see some of these children. And so it is a plea to consider making sure vaccine for children and the pediatric offices receive the vaccine, family medicine as well, earlier in the season. Because before we administer, we also pay attention to equity, and we need both stocks before we start administering. So that is my plea. The motion I'd like to make is to, is it 2 slides later? That one. So I was going to approve the proposal for the changes included in the updated language for the composition and the proposed changes to the recommendation for vaccine for all children.
Yeah, thank you. Dr. Groskopf, can you please put up the vote language for our team? Thank you.
Okay, so I was going to, my motion is to accept the language that we have on the table.
So it's been moved. I'm looking for a second. Ms. Bata?
Yes, I second that motion.
Okay, thank you. And we'll back to Dr. Cotton.
I just had a quick comment on this slide. I was wondering if it's really necessary to put the final few words where it says that all vaccination providers should be familiar and be certified in CPR. That makes us liable if we're not certified in CPR. And is that really necessary to put CPR in there?
That has been in there for some years now, and I think is taken directly from the general.
Okay.
Yeah, from the.
Okay, as long as it's not new.
I just looked it up, and it is in the general recommendations.
Yeah, and I believe it dates from the first time we started revising the egg allergy recommendations, which was about 10 years ago.
May I just, well, 2 things. One is, in terms of vote recommendations, I'm wondering if that could be in the body as opposed to the recommendation itself, because I think just distinguishing what's the actual recommendation from what's the body. The proposed recommendation on the table, just to clarify, is all persons aged 6 months or older with egg allergy should receive an influenza vaccine unless a contraindication exists. And then I'm assuming all of the rest of this, or the first bullet should be the recommendation or the first sentence, but everything else should be in the text or the body of the recommendation. Is that correct, Dr. Groskopf?
We could do it that way. In general, the egg allergy recommendations have had 2 to 3 bullets. It probably would not be difficult to remove the 3rd bullet and put it into the body. Perhaps a 2nd bullet as well. I think the concern is that if there's not some emphasis on the fact that severity is no longer an issue, people that don't read beyond the bullets won't see it, which happens probably sometimes. It's a big document, but.
And the second question, as it relates to this, is as more and more vaccines are being delivered in pharmacy settings, I'm wondering if that's actually constraining our ability to give it. I don't know if all pharmacists are certified in CPR. If they are, that's wonderful to know. I just don't know that.
I don't have any
Dr.
knowledge of
Good,
that
go
myself.
ahead.
Yeah.
Yeah, so as part of the immunization training, CPR is required for all pharmacists that are giving immunizations or vaccinations.
Okay, thank you for that clarification.
You're welcome.
Dr. Long.
Can you put the recommend? Yep, thank you. The first sentence. When I first saw it, I thought, Oh, I don't know what you're talking about. All persons aged greater than 6 months or older with egg allergy should receive influenza vaccine unless a contraindication exists. And then I thought about it and I thought, well, they're going to think about contraindications because of anaphylaxis to egg. But it was not ever, well, recently it's not been a contraindication. It probably has been a precaution. I just wondered if, for clarity, you would want to put unless a non-egg related contraindication exists. But does that wording then infer that a contraindication to egg did? So I just think I think people are going to be confused. They're still going to think that egg is a contraindication.
So egg allergy has been neither a contraindication nor a precaution.
Not even a
since
precaution.
about 2011-12. Sometimes it's interpreted that way, but it's not in the precaution. It's not in the contraindication precautions tables for flu vaccine, and hasn't been. It's so we've actually been even careful about using the language for that little recommendation for setting for the severely egg allergic. Some people refer to that as a precaution, and that just makes things very confusing too. But it hasn't been. So we actually considered something very much along the lines of what you suggested, but our read of it was that it sort of implied that it was a contraindication before, which it wasn't.
Okay, let's keep going. And then I think at the end, I'm not hearing any objections to the content of this recommendation. It's more just making sure the wording is clarified. So I think, Dr. Grosskopf, with the feedback you're receiving now, we can continue to do that and make sure we put up a clean language for the final vote. Dr. Talbot and Dr. Lair, you have nothing else?
Well, just thought I had a simple solution and realized I didn't. Because I thought we could say, with egg allergy should receive influenza vaccine unless another contraindication exists, but we've already said that it's not a contraindication, so.
Dr. Lair?
I would suggest that we change it to any influenza vaccine, parentheses, egg-based or non-egg-based, moving that up earlier so you have that clear distinction as opposed to the end of the sentence.
So I didn't quite hear all of that, but.
So second sentence, any influenza vaccine, parentheses, egg-based or non-egg-based, parentheses, that is otherwise appropriate for the recipient's age and health status could be used. It just emphasizes earlier that we don't care if it's egg-based or not.
Got it. Okay. So just moving the parentheses. All right.
Yes.
May I ask a question just for my clarification? Did we conclude that we want the third bullet moved to the text and not bulleted?
To be consistent with many other recommendations, we try to keep the recommendation just straightforward and simple, and then move most of the clarification to the text.
Okay.
Thank you. Dr. Paling?
And I wanted just to clarify, so what I heard, Dr. Lair, is to remove unless a contraindication exists from the recommendation, because that's always implied for every vaccine.
Can you state it, Dr. Lair, what you had intended?
That's not what I recommended. I just wanted to move the parentheses 5 words.
So just to clarify, any influenza vaccine that is otherwise appropriate for a recipient's age and health status can be used, egg-based or non-egg-based, for all persons aged 6 months or older with egg allergy. Is that what you're looking for? No?
It wasn't what I was doing, but it's fine. I was just moving the 5 words to emphasize putting the egg-based next to the influenza vaccine.
And I'm proposing, can we drop unless a contraindication exists, because that's true for every vaccine.
So second sentence goes to first sentence follows, drop unless a contraindication exists.
Okay, by second sentence goes to first. Do you mean that the sentence starting any influenza vaccine moves ahead?
That is what Dr. Lair proposes, I believe. Okay. No? Oh my goodness. Dr. Lair, read out your recommendation to us.
So I'm sorry, let me do this again. So I'm suggesting with Dr. Paling's recommendation, all persons greater than 6 months with egg allergy should receive an influenza vaccine, period. Any influenza vaccine, parentheses, egg-based or non-egg-based, end parentheses, that is otherwise appropriate for the recipient's age and health status can be used, period.
Thank you. Okay, perfect. Ms. McNally. Thank you. Okay. It seems we've achieved consensus on wording, so it's been moved and seconded, so we'll move that to the vote section, and we do have one more presentation. Anything else? All right. We'll move to the last presentation of this session. Okay. Of this session, I believe? Yes. Dr. Santoli.
So this is going to be a VFC resolution update for influenza. Next slide. So the purpose of this resolution update is threefold. First, to update the product table in the IIV component of the resolution. Second, to revise the eligible group section in the LAIV component of the resolution. And third, to add and or update the links in the contraindications and precautions section of both components of the resolution. Next slide. So for the inactivated influenza vaccine component, the eligible groups section has no changes. Next slide. In the recommended vaccine schedule and dosage intervals, there are no changes here. But on the next slide, you'll see that the table has been updated, the product table. You can't see the change in orange font because the change was a deletion, but we removed a product that was no longer available in the US. Next slide. For the dosages and contraindications and precautions sections, again, here you don't see changes. We did remove some guidance about the use of vaccine in egg allergic individuals because it was in the contraindications and precautions section. We thought that was confusing, and we actually instead added a link on the next slide to the details about the contraindications and precautions in the last published statement. Next slide. For the LAIV section, the eligible groups were reworded to kind of remove reference to the potential precautions for vaccination and just indicate that the eligible groups are non-pregnant children and adolescent aged 2 through 18 years. Next slide. The recommended vaccine schedule and dose interval section is unchanged. Next slide. The dosage section is unchanged, but for contraindications and precautions, we have updated the link in this section to match the latest published statement. And then the last slide. This is a statement regarding the update based on published documents. This is a standard statement for the resolutions, and it's not changed. It's as it was. And that concludes the update for the VFC resolution.
Thank you.
Could you go to slide 8? There is something there that I didn't read quickly.
Okay, sure. Which slide, can you indicate which slide that is, because we don't have them numbered?
2 slides before slide 10. You had slide 10
Is slide 10 numbered? Okay. So Lisa, if we could maybe.
I can't navigate to, we're on a different presentation now. I can't navigate to it. Natalie, could we go back to presentation 4?
This is.
Should we keep going backwards? Yeah, okay.
Two more. One more.
Oh, it looks like they all have the number 10, so that's not very helpful. I'm so sorry.
Can you go forward?
Well, I guess this is 1. So 1, 2, 3,
It was about the
4.
egg allergy. 5, go next.
It's the caution, okay, so it's I think it's 2 slides from now. Here.
So the number one, I'm sorry, number one, I'm not sure we need number one and number two. Oh, I see, they're different.
So those numbers, 1 and 2, under contraindications about egg-based IIV and cell culture-based IIV, if that's what we're referring to, those don't have to do with egg allergy. They actually have to do with severe allergic reactions to previous doses of flu vaccine. So they don't involve egg allergy at all, if that was related to the question.
Thank you. I didn't read it quickly enough. Thank you. I'm happy with this.
Are there any questions or clarifications for Dr. Santoli? And I will not take a motion on this quite yet. We're going to pause on the motion for this for a moment. Are there any clarification questions for Dr. Santoli? Okay. Clarification?
Yeah, just real quick. Why are we mentioning egg-based anymore? It feels like we should not even be mentioning egg-based anymore. That's all. So that's my question. Is that a clarification? I hope that's a clarification question.
Yes, sorry.
Okay.
I must be giving Dr. Brooks a look. You're good.
So I'm going to phone a friend and ask Dr. Grosskopf for help with this.
It is a really good question, and what this has to do with is the fact that about 3 years ago, we revised the recommendations for people who have had a previous severe reaction to a flu vaccine to be more in alignment with what's in the package inserts. Unfortunately, those contraindications and precautions in the package inserts that are related to reaction to flu vaccine are really aligned based on whether it's an egg-based vaccine or not. If you are talking about a non-egg-based vaccine, the contraindication is if you've ever had an allergic reaction to any flu vaccine, you don't get any other flu vaccine. But it's different for the non-egg-based vaccines. They don't have that blanket contraindication. So it is admittedly confusing. However, we have not had discussion about further revising it yet this year. So what's there reflects what's in the current recommendations.
So just to highlight that Dr. Santoli's last slide said if there are any changes to the way the recommendations are worded, the
Right,
VFC
they're
resolution will be
incorporated by
amended
reference.
accordingly to be consistent with the recommendation. So before we take a motion on this, my request is there's an additional vote that we skipped over for influenza. And if we're able to pull up that second vote. And Dr. Grosskopf, if you could please review the purpose and the vote language itself. I apologize we're going out of order, but it's important we get these recommendations in first before the VFC.
We weren't voting on anything until after public comment. No?
I don't think they're voting.
Right.
I think they just need to put it on motion on the table, then go to public comment,
And then do the votes. Got it.
Dr. Grosskopf?
Okay, so influenza vote number 2 is to affirm the updated MMWR recommendations and reports, prevention and control of seasonal influenza with vaccines, recommendations of the Advisory Committee on Immunization Practices, United States 2023-24 influenza season.
Questions or any motions? Dr. Paling?
I'd like to make a motion to accept the language as written.
Thank you. And these are our routine flu recommendations. Is there a second? Dr. Daly?
I second the language as written.
Thank you. It's been moved and seconded that we accept influenza vote number 2 as written on the slide. And now, if we can please go back to the VFC vote language, that would be helpful. Dr. Paling?
I would like to motion to accept the verbiage as written on the slide. Thank you.
So the influenza vaccine VFC vote, written to approve the VFC resolution for influenza vaccines. Dr. Daly?
I'd like to second the motion.
Thank you. It's been moved and seconded. We accept this VFC vote. So now we can pause this session. Thank you very much to Dr. Santoli and Dr. Grosskopf and Dr. Talbot, and we will move on to public comment. So give me just a minute. We just need to get our public commenters online, so please just give us a minute or two. Thank you.